Hello, everyone, and welcome to our Ask the Doctor session tonight. My name is Shelly Korean with Skypass Foundation. Seems like it's been a while since we've had one of these webinars. I think we did our April webinar in the beginning of the month, so it's been about 6 weeks since we've been together, but thank you guys for taking the time to join us tonight. May, as you guys know, is National Fitness Month, so we thought it would be appropriate to cover the topic of exercise and Parkinson's disease. And here to chat all things exercise and PD, we are honored to have our guest for tonight, Dr. Terry Ellis from Boston University. Dr. Ellis is an associate professor and chair of the Department of Physical Therapy and Athletic Training at the College of Health and Rehab Sciences at Boston University. She is also the director of the Center for Neurorehabilitation and the director of the American Parkinson Disease Association National Rehab Resource Center, that's a mouthful, housed at Boston University. She also has expertise in using mobile health technology to help persons with PD engage in lifelong exercise with the goal of improving overall mobility, community engagement, and quality of life. Love that. She's also published numerous articles and lectures internationally on topics related to exercise and PD. And one of her most recent published papers is actually the topic of our discussion tonight, and it's called Evidence for Early and Regular Physical Therapy and Exercise in PD. Dr. Ellis, thank you so much for being here. We know that there's a ton of information out there about exercise and PD, but we're so excited to hear your specific findings from your recently published paper as we get into that here in a minute. We also have with us Dr. Shilpa Chitnis here tonight. Dr. Chitnis is a Skypass Foundation board member and a movement disorder specialist and professor of neurology at UT Southwestern. And if you've attended our webinars in the past, you know that these Ask the Doctor sessions are interview style. So Dr. Chitnis will be interviewing Dr. Ellis on our chosen topic for tonight. Just a quick reminder that you can use the chat or the QA box at the bottom of your screen to interact with us throughout the conversation. And we got some questions with registration as well that we will address towards the end of our time together. Now, before we get started, let me just share my screen here quickly. As you guys know, Dr. Chitnis is a patient favorite, and she is a part of our family here at Skypass Foundation. Dr. Chitnis actually just lost her mom 4 days ago on May 21st. So we want to dedicate this episode of our Ask the Doctor webinar to her mom, Mrs. Hemalata Chitnis, dear mother of Dr. Shilpa Chitnis. She passed away on May 21st, and she was a dedicated and loving mother, wife, sister, grandmother, and friend. She devoted her entire life to her family and her work, and she raised her 2 daughters and her 9-year-old sister with love and kindness and instilled values of honesty, hard work, courage, and gratitude. She was fiercely dedicated to her loving husband of 58 years, and she will be most remembered for her kindness and courage to face any adversity with a smile. And we certainly see so many of those characteristics in you, Dr. Chitnis, and we are so thankful that you're here with us tonight. And I know that your mom would be so proud of the amazing work that you're doing here in the PD community. And we're just so grateful to be just a small part of the legacy that you are building as well. So thank you again for being here, and we happily dedicate tonight's episode to your mom. And with that, I will hand it over to you.
Thank you, Shelley. It's just you never know how hard it is to lose somebody, especially a mother, until you lose it. And it's just hard. But, life goes on and the show must go on. So I'm really happy to be here. And I'm really happy to be with you and Dr. Ellis. So advances in medical management of Parkinson's disease have really resulted in living longer with disability. Although disability worsens over the course of the disease, there are signs of disability even in the early stage. And I'm really reading this out from, Dr. Ellis's paper. Several studies reveal an early decline in gait and balance and a high prevalence of non-motor signs in the prodromal period that contribute to early disability. There's also growing body of evidence revealing the benefits of physical therapy and exercise to mitigate both motor and non-motor signs while improving physical function and reducing disability. So I'm going to jump right into question number 1. And what I'm going to ask Dr. Ellis is if you can tell us, about the presence of disability at diagnosis, and also walk us through the natural history of progression of disability in Parkinson's disease.
Sure. Okay. Well, I think as many people know, living with Parkinson's disease, there are symptoms that emerge even well before the diagnosis. And a lot of times people don't know they're associated with Parkinson's disease until finally, they get a diagnosis of Parkinson's. And then, early on, some of the things that people talk about, things like from the motor side, let's say, now things like maybe stiffness in the shoulder or stiffness in the neck or back. That might be one of the early things that people talk about, and it can even lead to maybe a decrease in flexibility or range of motion in certain joints, particularly the shoulder and the back. And then, some people might notice like subtle changes in walking, slowness of walking, or maybe dragging a foot, or arms. The arms aren't swinging, and as much as they used to. And even things like in standing, an increase in sway just with standing still can be one of the things that we see early. So those are on the motor side. Then there are some non-motor symptoms that people can experience really fairly early on. Things like, difficulty with sleeping and some changes in sleep, for example. Some people complain of quite a bit of fatigue early on. Even some issues related to thinking clearly or multitasking, doing a lot of things, at the same time. It just might be a little more effortful. And so those kinds of things, although they're not significantly altering one's life, and people tend to still be doing the things that they were doing, but there's subtle early signs of like markers, let's say, of disability that may be amenable to treatment, and particularly exercise. So exercise has been shown to improve aspects of walking and to improve balance, and in some cases to improve fatigue, and in other studies to improve thinking. And so my point in the paper is like, why are we waiting? Why are we waiting to start exercise later or to refer to physical therapy later in the disease when there's more overt disability? Why not start early when success rates can be higher, when things are more amenable to change? And people, in my experience, people want to be as proactive as possible early on. So for those reasons, it makes sense to, start earlier.
Absolutely. Sorry, turn the thing on. No, this is excellent. And what I want to do next is my next question is going to be about. It's going to have three subdivisions, and the first thing I'm going to ask you is, as you correctly said, that early changes in gait are particularly concerning. What can you tell us about step count in patients with Parkinson's?
Yeah, I mean, if you just look at overall physical activity, which can be measured many ways, but we've measured it quite a bit using step counts. And what we see are, in general, people with Parkinson's tend to be about 30% less active than people without Parkinson's of the same age. So there's something about Parkinson's that's leading to this sort of less activity early on. And it's like, why is that? Is it because, physical activity feels more effortful? Is it because of things like maybe some depression or apathy, and, so sort of at the behavioral level, not really, not being able to fit it in, or not feeling very motivated to do it? There's lots of different reasons, but, we do consistently see that physical activity as measured by just amount of walking is definitely reduced. And not only is the amount of walking, the amount of steps somebody takes in a day tends to be reduced, but the intensity of the steps tend to be slower. So, which makes sense, right? Because Parkinson's is associated with slowness or bradykinesia. So we see that the steps are slower and not as many. And it turns out in some of the studies that we've done that those are modifiable. We can work with people with Parkinson's and they can walk faster and they can take more steps. And, and particularly early on, so it's even, it just highlights the importance of, hey, these things might be subtle and might kind of sneak up on you and might not alter your sort of everyday life, but they're definitely there, particularly if you measure them. And we can do something about it.
Absolutely. And I think you kind of answered my, part B, which was going to be gait speed. I don't know if you have any other comments.
Yeah, I mean, gait speed is, we feel like is a sort of a kind of a red flag. It's a red flag that, hey, there's some changes in walking that are going on here, and we should be intervening and doing something about it. People might notice that, hey, when I walk with my family, I used to be kind of out in front, but now I'm further behind. Or over time, I realize I sort of slow down as I walk further and further. Or sometimes I hear my foot drag, those kinds of things. And, although they might not be, you're still walking and people are still moving around, but these subtle changes can add up, and they can add up, but they're amenable to change, which is why we should be acting as early as possible.
Yeah, absolutely. And just segue into, loss of postural control, which can be an additional sign of, early disability and PD. And basically, historically, we used to teach med students or residents that, by the time falls happen, you're probably in stage 3 or stage 4 of the disease. And, clearly we're finding out that that's not the case. So what are your comments on that?
Yeah, I mean, so there's been a few studies that have been done lately that have started tracking people, from the point of diagnosis going forward. And it turns out that if we look and we measure and we're sort of aware of this early on, that there's more people falling earlier on than we originally thought. And even at the point of diagnosis, people can often reference a fall. Oh, I did fall, 6 months ago, or I have had 1 or 2 falls. So it's not a lot of falls, but it's the fact that they're happening, and they're happening earlier than we used to think. And so one of the main things I try to get across in this paper is there's been 2 really large randomized controlled trials that have been done looking at trying to improve balance and reduce fall rate in people with Parkinson's disease. One of those studies was done with a couple hundred people in Australia, and another one with over 500 people in the UK. And one of the, we've always sort of thought, well, you want to improve balance and reduce falls, but a lot of those studies are done in the later stages when there's a lot of falls. And we can still help people at that stage, at any stage. But what these 2 studies showed is actually the people who benefited most were people who were earlier in the disease process, who had fewer falls to begin with. And those were more sort of amenable, to reducing, in frequency. So it just shows, it kind of makes the point that, hey, even if you're not falling or you're falling infrequently, you still want to work on your balance. You still want to work on your balance and participate in an exercise program that really challenges balance.
Yes, absolutely. And I certainly endorse that. So just coming back to what you said about, several non-motor signs are clearly present during the prodromal period or at the point of diagnosis. And so, these can be excessive daytime sleepiness. We talked about depression and anxiety. We talked about a lot of cognitive phenotypes, fatigue, autonomic dysfunction, and pain. And so my question to you is there any evidence that exercise can actually target non-motor symptoms?
Yeah, the exercise the literature isn't as strong in this area, mostly because most studies in exercise focus on the motor side. And then they might measure some of the non-motor symptoms, but they're not primary outcomes in the study. So sometimes the studies aren't powered enough. They don't have enough people to really show that there's a difference. And then a lot of the studies that do target non-motor signs are small. They're smaller in nature. So we might get some information on 20 or 30 people or so. So definitely much more is needed. But there are some of the studies that look at aerobic training and strength training, for example, that do show some improvements in cognition. But they need to be reproduced. There needs to be bigger studies and more emphasis on this. Things like fatigue, the jury's still out on that. Some people really benefit from exercise when they experience fatigue, and other people feel like, no, it didn't help me or it made it worse. So it's really, and then you have to really kind of tailor it to the individual and figure out, okay, for this person, what's the best way to go here? So I think there's some evidence to suggest that exercise could be really important in treating the non-motor signs, but we need more evidence.
Yes, without a doubt. And before we, jump into the individual trainings, I really want to ask you, like, what do you think at the molecular level? What do you think exercise is doing to us, or what is it doing? What is it going to do, especially for patients with Parkinson's disease?
Yeah, it's a really good question. I mean, most of the work has been done in animal models, looking at aerobic exercise or cardiovascular exercise. There's been a little bit done in humans, using PET scans or, TMS, for example. But in humans, we can't directly measure, there's no biomarker, right? So we can't directly measure, changes in disease progression. The same goes for pharmacological studies, right? There's no biomarker, there's no way to know for sure what's exactly happening in the substantia nigra, of the brain. The idea is that's been suggested in exercise studies of animals is that there seems to be more dopamine release, so more dopamine availability with the rodents who are exercising, especially exercising vigorously. There seems to be more in humans, more BDNF or more neurotrophic factors. So these chemicals that seem to promote better health of the cells or slow cell death. So there are some real chemical changes that occur in the brain that we think might be associated with mitigating the symptoms and perhaps slowing the progression. But much more is needed. In human studies, the biggest human studies that have been done in aerobic exercise, so with about 130 people with Parkinson's, the SPARKS trial or the Parkin-Shape trial, they have found a reduction in the progression of the motor symptoms of Parkinson's with aerobic exercise for 6 months. Now, we still don't fully understand, is that a symptomatic effect? Just like medicines, is it just dampen the motor, the motor signs, or is it actually slowing the progression of the disease? And we're not sure because we don't have a sensitive enough way to actually measure that. But nevertheless, if the symptoms are less, that's a good thing. That's what the medicines do. The symptoms are less, that's a good thing. It usually leads to better function.
And I can add a clinical perspective there because, sometimes I see a patient and I'm talking to them and I do their, the MDS, UPDRS, Unified Parkinson's Disease Rating Scale, which is the testing that we do. And you look at their scores and I'm like, wow, your score is like 8. And, of course, I don't want to focus on scores because I know how patients are, because then they want to know what's my score. But I look at their score and it's like 10 or 12. And then I go back and see, how many years have you had the disease? And they're like 10 years, and
Yeah.
what is the distinguishing factor is the extent to which these people really exercise, and I've always found, and obviously this is not in a clinical trial, but I've found people who exercise lower UPDRS scores, better quality of life. So, I clearly endorse the clinical evidence to what you're saying. And so maybe we can talk a little bit about, various modes. So two things, walking as well as treadmill. Like I'm always trepidatious of treadmill, because I have no idea who's gonna like fall. So maybe you
Yeah.
can cast some light on walking and treadmill and who should do treadmill and who should do walking and who should not do them.
Yeah. That's a great question. The treadmill can be very, very helpful to improve walking early on because as in Parkinson's, the walking with continuous walking, it gets a little slower and a little slower over time. And so what a treadmill does is it serves as a pacer, an external pacer. So when that belt moves, it basically prevents you from slowing down, and it keeps the walking at a certain pace, and it forces people to take a sort of bigger steps, right? And an overall faster walking. So it can be very effective to get both aerobic training and an improvement in walking. However, for people who fall, for people who feel unsteady on their feet, for people who have freezing of gait, the treadmill might not be a good idea. You don't want to, the last thing you want to do is fall, right? And get injured. So, but you can still get an aerobic exercise. You can still engage in aerobic exercise by doing something like riding a stationary bike. That was the Park and Shape trial, one of the biggest trials that have been done. They did aerobic exercise on a bike. And then the Sparks trial, they did aerobic exercise on a treadmill, and the results were very similar. They were comparable. So what that means is that it doesn't matter the kind of mode that you choose. What matters is the aerobic nature of the exercise, making sure your heart and lungs are working, you're sweating. It's a little difficult to talk. When you think about a scale of 1 to 10, you're working at, at least like a 6, maybe a 7, and that, that can be done on a bike or a treadmill. So when people are trying to decide, one of the things I ask them, well, what are you most like? What are you going to stick with? What is going to lead to the most kind of adherence, to the program, because that's one of the keys to exercise is doing it regularly. And so that's one factor. And the other factor is safety. We want to make sure people are safe and getting the most benefit. And so thinking about that when we're trying to help people decide what to do.
That's excellent. And so, segueing into, resistance training, like, not everybody, likes weightlifting. Not everybody has, the access. I mean, if you don't do your, muscle groups correctly, if you're able to go to the gym and use those machines, then you're probably doing it a bit better. But, you still, I always, worry even when I exercise, am I doing this? Of course, I've been working with a trainer, so I know exactly what to do, right? So, what do you think? Like, is resistance training necessary in Parkinson's patients? And what is the evidence on that?
Yeah, the resistance training is particularly helpful when someone's experiencing bradykinesia. It helps with faster movement and getting that force out. And there was a study done by Daniel Korkos, and he looked at people with Parkinson's over 2 years. And he saw that people with Parkinson's who did progressive resistance exercise. So that means it has to continuously be challenging. You can't just do the same exercise over and over again every day for 2 years. It has to be a little bit more challenging, sort of week after week. And that can be done in a variety of ways. And the people who did that, they had less progression of their motor symptoms compared to people who did kind of a low intensity strengthening, stretching program that wasn't progressed. And so the other thing is that people think that weight training has to be done with big weights in a gym. And it really doesn't. You can use body weight even. Think about things like a squat or getting up out of a chair, right? Which is the same movement as a squat. That if you do that repetitively, and again, in a safe way, like with a chair up against a wall so it won't move, and going up and down, you can do several repetitions of that and really strengthen the muscles in the legs, the lower extremity extensors. And that can be a really effective exercise. And it also helps people get in and out of a chair, so they can be a real functional gain from that. So there are programs, we did contribute to an exercise program that you can get for free online through the American Parkinson's Disease Association. And that has pictures of strengthening exercises that people can do at home with no equipment. So free, easy, just in the home environment. And so, the way to make it harder is doing more repetitions.
Yes, absolutely. So let's talk a bit about, we've obviously talked about falls, but let's talk a bit about balance training. And also, maybe, I know you did not mention, LSVT big was not really mentioned in your paper. And I don't know whether there was a reason for that. But, I would also like to know what's your opinion on that. We refer our patients to LSVT big, and I know they do get better, but, what's your experience?
Yeah, so I think balance training can be done in lots of different ways. There's it's sort of just like aerobic training. It doesn't really matter if you want to use the treadmill or the bike. Balance training, it just has to be challenging. It can be done with Tai Chi, dance. Some forms of dance can improve balance. There can be just sort of standard balance exercise programs. So there's lots of ways to improve balance, which is great because it gives people choices. It gives people the ability to choose something they like and they're going to stick to. With regard to LSVT big, I think the idea there is that people, Parkinson's is kind of what's characteristic about Parkinson's is the small movements, right? The hypokinesia, the small movements, a small arm swing, small steps, small voice, small handwriting. And so what the LSVT big program focuses on is big movements, and through practice and through cueing. And that can be very helpful. But it only works while you do it. And so just like with any form of exercise, it really needs to be continued. And so whether you're going to continue treadmill training or a balance exercise program or Tai Chi or LSVT big, it doesn't end at the end of the program. It has to be continued, but it's a form of cueing. So people learn, okay, what do I have to tell myself to move big? What do I have to remind myself of? And then if people learn those strategies, then they can continue to use those and apply those over time, particularly when they keep practicing the movements.
Yes, absolutely. And so is there any evidence that balance training could also contribute to improvement in non-motor symptoms?
Not enough, there really isn't. Balance training, all the studies in balance training mostly focus on motor symptoms as their primary outcomes. Occasionally there's a secondary outcome that's on the non-motor side, but like I was saying earlier, they're usually very small numbers and a secondary outcome. So they tend to be kind of inconclusive.
Thank you. So the highest quality evidence available to date suggests significant ability to reduce fall rates for those with mild to moderate disease. But in those studies, those patients with most severe disease did not benefit and even appeared to have increased fall rates as a result of training. And how do you explain that?
Well, that's a really good question. I think we explain it because these studies don't account for increase in physical activity level with an exercise program. So if you look at rate of falls in comparison to time on your feet, then we may not actually see an increase in falls. It might be relative to the amount of time people spend in upright. And so in some of the more recent work, people are starting to look at that more carefully and accounting for that, because I don't think that actually exercise is making balance worse in the late stages. I think that people are doing more and they're up more and they might be taking more risks. That could be a factor. We don't really know because it wasn't measured in that way, but I think it's something that future trials are gonna measure and account for.
Yeah, absolutely. Um, I think people feel better, people feel more confidence to get out and do more. But of course, if you're a stage four, you're a stage four, of course, so you got to, people forget their walker. And a lot of the times the question I ask patients is, um, if you were to use your walker, would you not fall? And they're like, because they don't want to use the walker, they're like, no. And you see the spouse sitting next, they're saying, yeah, yeah, yeah. If they were to use the walker, they would not fall. So clearly, like, I mean, nobody likes the walker, obviously, and I won't like it either when I'm old. But, if I'm going to be falling, I hope God gives me the wisdom to use it,
Yeah.
I've told my patients over a 30-year-old career. So coming to the holy grail, literally, of Parkinson's disease progression, and that is freezing of gait. You
Mm.
know, so that's something that we have all struggled and have used so many different strategies, whether it is obviously exercise, whether it's uh, you know um, medications, you name it. But that has been one area where really, and I know Dr. Zog in Canada has used spinal cord stimulation to try to see if that would improve freezing of gait. But I think that's something that really eludes us. So what can you tell us about external cueing, as really way to improve the various aspects of gait? And my second question right in there is that there are several wearable devices now that are available that might potentially show, promise to overcome freezing of gait.
Yeah, it's a great question. It's really, it's a tough problem, and one that really impairs people's ability to function and engage in society. And it's probably one of the most challenging things we face. In So it's been shown that sort of a general exercise program doesn't really help freezing of gait. It's got to be really specific to the task. And so one thing that's very effective in the moment is some sort of cueing. So, for example, people who have trouble initiating walking with a freeze, freezing with a gait initiation, or freezing going through a doorway, or freezing going over a threshold, things like that. Visual cues can often be effective. Lines on the floor, a laser pointer, the walker with the laser, all of those kinds of things, because it helps give a cue to take a bigger step in the moment. So that those things can be helpful. It's not curing freezing, it's not preventing freezing. It's just trying to provide a strategy, right, to overcome freezing in the moment. People who freeze with continuous walking, they're walking for a while and then start to freeze. They tend to benefit more from a rhythmical cue, to keep walking more rhythmical and to keep the steps big. So things like a metronome or music, for example, at a particular cadence. And that has to be tailored to the individual. But now there's more emphasis on devices. And like, for example, what if there was a device that could identify freezing in just as soon as it started to come on, or maybe even before it came on? And then there could be some sort of cue given through a device in which people could alter their gait, take a bigger step before they kind of went into a freeze. So there's lots of promise there. We're actually in the middle of a study, just getting a study going, actually, using a device in which measures the cadence or the step rate with a sensor on the shoe. And that gets fed into an algorithm in a phone. And people are wearing a headset, and they play, people pick the kind of music they like, the genre of music. And the phone will play a particular song that the person picks, something they like. And then that song will alter their rhythm, the tempo, to match the cadence, the walking pace. So the song is kind of stretched out or condensed to match the walking pace. And then the idea is that you get the person to walk faster and faster. So the beat picks up in the song, and then the person walks faster and faster. So this is a more kind of tailored approach, because it's measuring what that person is doing and then providing some cueing or some input. And we're trying it right now on people with Parkinson's disease with slow gait, no freezing. But ultimately, I think there's potential for something like this and other devices to detect freezing early, so that we can change the gait pattern before people get into a real freeze and fall. So that's the goal. But I think it's in our future. I think it's going to be possible to do that.
Yeah, just something like a cardiac defibrillator,
Yeah, exactly.
that would be really something, very very important. And obviously freezing of gait, being two kinds, so levodopa responsive versus levodopa non-responsive. And so are the mechanisms different in people that have levered? I don't know the answer to that myself, honestly. The mechanism's different in freezing of gait that is, off dose versus freezing of gait that's on dose. And, people have looked at the role of the pedunculopontine nucleus, and people have tried to use, cholinesterase inhibitors like, rivastigmine and donepezil to see if gait could improve, or, droxidopa or Ritalin. And then people have also tried DBS in the pedunculopontine nucleus to try to improve that.
Yeah. And nothing has really, panned out. I think it's the most, one of the least understood areas. I don't think we know the answer to that question, or I don't either.
Yes.
So it's very tough. It's very tough. It's one of the hardest things to, to sort of wrap your head around and try to help people with. I think we do a pretty good job of helping people in the moment, but still it's very hard too. And we find it's really hard for people, even when they know the strategy, to apply it in the moment, because they're doing other things. They're distracted. They're dual tasking. They're talking, or they're carrying something, or engaged in something else. So it makes it really hard to focus on the walking.
Yeah, this is a question more for myself than for the patients. What is dual task walking?
Oh, okay. So dual task walking, so we look at both single task and dual task walking. So we might have someone walk 10 meters, and we time, how long it takes them, how much distance they cover. Well, for the 10 meter, we time them to see how many seconds it takes. So we get an idea of gait speed. But then we do it under dual task conditions. So we ask people to think about something, and we usually do, you're subtracting, you start at 100 and subtract sevens, and you're doing a math calculation while you're walking that 10 meters, so that we can see what happens to the walking when you're dual tasking, when you're involved in more than one task. We're trying to simulate, when you're walking around, you're doing something else with your mind. You're not typically not thinking about walking, you're thinking about where you're going or a conversation you're having. And then sometimes we look at a motor dual task, where people are carrying something, or maybe talking on the phone, or plugging in a number or something. And what we find is that, under dual task conditions, people with Parkinson's have even more slowing of their walking than people, that don't have Parkinson's. So what that means is that when people are walking just a single task, people with Parkinson's, a lot of that cognitive attention is focused on walking, because walking isn't automatic. That, in Parkinson's, we lose that automaticity. And so because it's not automatic, there's some level of thinking going on and attention geared towards the walking that makes it a little slower, but not a lot slower. Then when we add on a dual task, like a cognitive task, it takes that cognitive attention away from walking and draws it to the cognitive task. Then we see a much more significant slowing of walking. And that tells us that walking is not automatic, and that there's a significant cost to dual task walking that leads to slowing of the walking, and usually like a decline in the ability to perform a cognitive task. It's like the attention is split in too many directions, and it's hard to do anything. And so, there was a large study that came out on the duality trial by a group in the Netherlands, Alice Neubauer, that group. And they did a study trying to train dual task walking in people with Parkinson's. And they were able to show that, after, kind of robust treatment, that at the end, people were better at it. So there was some, and they're trying to speculate what's going on in the brain. What's going on in the brain that might account for improvements in dual task training. We know gait doesn't become automatic, but there might be some elements of gait that become a little bit more fluid, and take a little bit less attention just with all the practice. So, that it is something, and that's something that we see early on in people too, a decline in dual task walking. It's something we can train early on.
And if I can share a quick personal experience, whether you have Parkinson's or not, don't have Parkinson's, please do not play with your cell phone when you're walking, because Dr. Chetnas was in China, in Shan, and not paying attention, and suddenly a set of stairs appeared in the middle of the long walkway and flung me over 2 feet, and I literally tore my deltoid, and it took 6 months to heal. So please don't some of us, knowing that we shouldn't be doing it, end up doing it. I'm not doing it anymore, but
Wow.
I really want to spend at least like the last 5 minutes talking about your secondary prevention model. But before that, I really want to just get you there are a lot of community-based exercise programs that have now come up. So there's Tai Chi, there's dance, there's boxing, and maybe your 2-minute spiel on what do you think about those?
All of those different things.
Yeah, just all of them combined. Or
yeah, I mean, it's like boxing has gotten a lot of press, a lot of marketing, and I would say it's not the boxing per se, it's that boxing consists of elements of exercise that we know are effective. Aerobic exercise, some strengthening, some balance training. And then boxing has the added benefit of socialization, camaraderie, that people really enjoy. And a lot of people benefit from going to a class because it's a lot easier to show up and just to do it when someone else is leading the class than it is to motivate yourself to do it by yourself at home. So a lot of these kind of classes, Tai Chi, dance, boxing, pedal for Parkinson's, all kinds of things like that are great ways to exercise and to do it with people, in an environment in which there's lots of support. I would say that most people, though, go to a class once or twice a week, and that isn't enough. And so going to a class is great, but then it usually has to be supplemented by some other forms of exercise on other days of the week to make sure people are getting what they need.
Yeah, absolutely. So, I remember in 2010, the American Academy of Neurology published the first set of, what they call quality measures for treatment of patients with PD. And I remember creating like a smart set to tick those off. And they really recommended to discuss the needs for not just PT, but also OT and speech therapy on an annual basis. I also know that the UK, NICE, which is the National Institute for Health and Care Excellence, went a step further, recommended referral to PT early in the course of the disease. So in spite of the fact that there is evidence, there is support, the utilization of PT services for patients with Parkinson's disease in the United States is remarkably low. And what is the explanation for that? And how can we improve that?
Oh, we need to improve that. I think it's multifactorial. I think people think, well, that, I'm doing fine. I don't need any rehab yet. I don't need any rehab early. Or a lot of people don't know what physical therapy, occupational therapy, speech language pathology, what they would do with someone with Parkinson's disease. So some of it is just education. I think over time, several years ago, we didn't have good exercise studies. It's only been in the last, couple of decades that we really have more of a robust body of knowledge showing the benefits of exercise. So some of it has been, getting the word out to the neurologists who tend to refer, to the rehab professionals that, hey, this is really important. We do see that neurologists tend to refer more to rehab than non-neurologists. So neurologists seem to be more, knowledgeable about the benefits of exercise. So I think there's lots of things. I think people with Parkinson's disease worried that, is this going to be paid for? How is this going to be paid for? How does that work? How do I find how do I find a physical therapist or an occupational therapist or a speech therapist who knows about Parkinson's? Because just like doctors who specialize, physical therapists and other rehab professionals also specialize. And so a lot of physical therapists specialize in orthopedics or sports injuries. So they wouldn't know about Parkinson's really, so you want to go to the right person who has some expertise. So all of those things can sometimes make it difficult to get referred, to find the right person, to know about the payment, all of those things kind of present barriers. Now these barriers can be overcome, but people need to know more. Physicians need to know more, patients need to know more, and therapists have to be better trained, in this area.
Yes, absolutely. And I think, patients will sometimes ask me, I need like a gynecologist. And is there a gynecologist that specializes in Parkinson's? And I said, no, not a gynecologist and not a dermatologist, but, maybe PT and ST for
Yeah.
sure. So I have two last questions. This has been excellent beyond any measure, even better than I, initially envisioned it. And I've learned some things from reading your paper and asking you these questions. So the two things I want to say is, so question number one, comparing the suboptimal standard of physical therapy care with your secondary prevention model. And what can you tell us about that?
Yeah, traditionally, people with Parkinson's go to see a PT or an OT or a speech language pathologist at stage 3 or late in the disease, 7, 8, 10, 12 years in. When something goes wrong, and they come in for an episode of care, it might be, 6 visits, 8 visits, 10 visits, whatever it is they need. And then they leave, they're discharged at the end, and they have an exercise program. And usually they don't do it and they don't come back. Like physical therapists, if you think about it's different than an injury model. That might work. That model might work for somebody who gets hurt. A person who gets hurt has an orthopedic injury, who breaks a bone or strains a muscle or whatever it is. And you come in and you get physical therapy and you leave much better. When you're dealing with a chronic progressive disease like Parkinson's, it can't be just one and done. It can't be just one episode of care and you're done. So what we recommend is that people come in early, preferably at the point of diagnosis, so that we can do some tests of balance and gait and ADLs and quality of life and design an optimal exercise program, to meet that person's needs. And then we recommend that people come back to a physical therapist every 6 months or annually. Just like you go back to see the doctor to get medication adjustments, you go back to the physical therapist to have an exercise adjustment. I would recommend that for speech therapy too. You have to go back and say, okay, let me do the test. Let's see what's going on with my voice. Do I have to change my exercises at all? Well, my walking has changed, my balance has changed, or it hasn't changed, Sometimes we call it the dental model because people sort of resonate with that.
Yeah.
You go to see your dentist every 6 months or every year, whether you have a problem or not. And you know what? If the dentist does all these tests and cleans your teeth and says, you know what, you look great, you don't need anything else, you leave happy. That's a good thing, and if the dentist, maybe the dentist finds a small cavity, or maybe the physical therapist finds a small change in walking, and then you can intervene more successfully, more quickly, less expensively, at that point in time. So we recommend that people form your rehab team. Form your rehab team, your PT, your OT, your speech pathologist, maybe a nutritionist, depending on what people's needs are. And then, and then you have them when you need them. And you can go back and follow up periodically to get tune-ups, adjustments in your program.
Absolutely. I think this is very important. And one of the rule that I have for my patients is that they have to see a PT and they have to see a speech therapist twice a year. Like,
Yeah.
irrespective of how well or how badly they're doing. Of course, if they're doing badly, they ask for it. But, I usually, and then I think that insurance certainly can pay for this. I can make a justification for that. So, my last question is really, I have a history of grandmother, mom's mom with Parkinson's disease. There may be others who may have more than one family member, and they may wonder about what can I do. I always get asked, what can I do so that I don't get Parkinson's disease? Of course, if it's genetic, depending on the transmission, that they could do nothing unless there is a gene splicing treatment that will eventually be available. But things like caffeine, right? I mean, you can safely drink caffeine, but certainly I don't recommend anybody to smoke.
Yeah.
The thing that you could possibly do is exercise, right?
Yeah. Large epidemiological studies have shown a significant reduction in risk of Parkinson's with high intensity exercise. The impact has been a little stronger in men than women, but nevertheless, it's there. So it's, if people feel like there's a risk, an increased risk, of Parkinson's in their family, definitely I would recommend real commitment, to high intensity exercise. Absolutely.
And thank you so much. So that, of course, was you know barrage of questions from me, but I think the paper was so fantastic that it really helped me organize my thoughts and walk through the entire process. And I hope it was very helpful to the attendees. I'm going to read out a number of questions. So this is one question. Susie, thank you. I really appreciate your thoughts. Prayers to Dr. Chitnis and family. Um, is it better to exercise during on time or off time? Of course, it's a no-brainer, but I'll let you answer it.
Yeah. You want to exercise during an on time because you want to be able to get the most out of the exercise program. And when you're on, you're able to move more easily, more fluidly, and and safely. So exercising during an on time is really key. So that means it has to be planned out. For people that experience fluctuations, planning out, okay, I'm going to take my medicine at this time, and this is when I do my best. That's when I'm going to exercise. Yep. Great question.
Absolutely. And a few other questions. Have you tried the desk cycle? It exercises knee and hip joints while sitting. I have found it helpful. Thank you. This is a question from Susan Hackett.
Yeah. I mean, sometimes that can just help with just keeping your joints moving, particularly people who feel they have a lot of stiffness or a lot of rigidity. So, that might help move the joints, while sitting. The other rule of thumb is people with Parkinson's really shouldn't sit for more than an hour at a time. There should be at least 5, ideally 10 minutes of walking and moving around for every hour of sitting. So sitting, the longer you sit with Parkinson's, the more stiff, the more slow you feel. So, moving more frequently through the day and avoiding those prolonged periods of sitting is really helpful.
Yeah, absolutely. Linda Chef wants to know, is there such a thing as too much exercise?
Well, there's been an occasional case of, only a few cases that I know of that people feel sort of depleted, but those examples, like I've seen it when someone has done a marathon, for example. So really, really a lot of exercise. So typically the problem is much more in the direction of not enough exercise. I rarely see anybody that's doing too much. So, it has to be pretty extreme. And it might be that there's just not enough medication on board for that kind of extreme exercise. But it's very rare.
Yeah, but certainly you don't want to injure yourself. I mean, you want to be,
Yeah,
you know,
exactly.
like I remember, like, in the past, now I have become I figure I got to practice what I preach. So no matter what happens, I'm usually come and do my 30 minutes on the elliptical or on the, on the bike or take my dog for a walk. But I remember, like, in the times when I didn't exercise regularly, and then suddenly I wanted to start, and I would say, okay, I'm going to the gym, and I spend like an hour and a half, and I
Yeah.
can't exercise for the next 3 weeks. It's so stupid.
Yeah. So gradual transitions are really, really important.
Yeah.
That's true.
And talking about off and on, Mr. Desai wants to know, I don't know if I'm on time or off time. And I know that there are people like that. I'll add my 2 cents and I'll let you, say, I'd say, like, maybe an hour after you have taken your medication is when maybe a good time, right?
Yeah, absolutely. And if you don't really feel a difference between an off and an on time, then it doesn't really matter. You're fine to probably exercise at any time. But yeah, like about an hour after you take your medicines, usually you'll, sort of, that's like peak performance. Yeah.
Yeah, and as a comment from one of my very, very nice patients, Sharon Roberts, says exercise early. It's your best friend, Dr. Chiknas's words. I endorse the same philosophy. Obviously, we work in the same arena, although doing different things. But certainly, making exercise your friend is really, when people ask me, like, what do I do? And I say, make exercise your friend. And, I mean, there's a philosophy about, like, do you treat as soon as you diagnose, even if it's early Parkinson's versus you don't treat. And different people, my philosophy is treat, because I think there's some evidence there. But certainly, making exercise your best friend and continuing them. And it's not just PT, but also speech therapy. Once you do the
Yeah.
training, do the, and there's evidence to say that people who do programs, but they do not do the maintenance programs. And that's why, Samantha Ellendery, big shout out to, Parkinson's Voice Project founder, has also created, like, the Loud Crowd, which is a maintenance therapy. So, you got to do your whatever, 4 weeks or 3 weeks, 4 days, whatever it is. But then after that, you got to do your maintenance therapy. That's,
Yeah, you got to keep it going. Exercise is a lifestyle.
yes.
It's not just a one-off. It's got to be a real lifestyle. And if you do it for long enough, if you get yourself into it and do it for long enough, then you feel the benefits. And feeling the benefits gives you motivation to keep doing it. So,
And I think with that was the last question. Shelly, unless you have any other questions, we're making perfect time. Like, this is the first time I've actually made perfect. I really moderated the time because I wanted to make sure that, I want to respect your time, because also on the East Coast. So thank you, Dr. Ellis. My gratitude. This is
I can't thank you enough for inviting me. This is great. It was a pleasure to be here. I'm always happy to talk about exercise, and what you guys are doing there is fantastic. I imagine all your patients are exercising.
hopefully.
Thank you, Dr. Ellis. It was such a pleasure to hear from you and such great information. And I personally really enjoyed reading through your paper as well, and just researching some of those findings that you shared with us. So thank you for that. I know all of our patients enjoyed it. Just want to remind everyone that we actually have a partnership with Tribe Wellness for group class exercises as well as physical therapy. So if you're interested in group class exercises, those are being held online, or if you're in need of physical therapy and finances are a restrictive factor for you, we want you to know that these services are available and financial assistance is available. So please take advantage of that. There's more information on our website at skypassfoundation.org, or feel free to reach out to me at info@skypassfoundation.org, or even directly to Dr. Mike if you have access to him, and we'll be happy to pass along some information about that. And with that, we will call it a night. Thank you everyone again for joining, and have a great night. Thanks, Dr. Ellis.